My name is Aubrey Reiner, and the purpose of this video is to demonstrate proper technique for a postpartum fundal height assessment. So we have our patient here. Let's call her Miss Kilgariff, and she just had a vaginal delivery. We are in the initial recovery phase after this delivery. Her placenta has just been delivered, and now we are going to check to make sure that her uterus is contracting down, that it's firm, and that her postpartum bleeding is under control. So first we want to explain to our patient what we're going to do. Miss Kilgariff, I am going to pull down your blanket here. I need to rub on your belly to check the top of your uterus to make sure it's nice and firm, and make sure that your bleeding is under control here. So what I'm going to need you to do is lay down and relax. I'm going to have you bend your knees up here. Of course, this doll's knees do not bend, but we would want the knees bent up so the feet are planted on the bed, and have them lay as flat as they can. That relaxes the abdominal muscles so they're not fighting against your palpation here. So I'm just going to pull back your gown a little bit here, and I'd like you to take a deep breath in, and then when you exhale, I'm going to rub on your belly here. So when I go to do a fundal height assessment, I usually start at about the belly button. You want your fundus, or the top of the uterus, to be at least at the belly button, if not lower. So we start at the belly button, and we can work down if we need to. Of course, we would be wearing gloves for this. We want to cup the lower uterine segment, just support it as you're pushing on the top of the uterus. So you don't want to push so hard that your uterus can actually kind of turn inside out and come through the vagina if you push too hard without supporting it. It's very rare, but of course we want to make sure that we're being very safe here. So we support the lower uterine segment. We go in at the umbilicus, and with fairly firm downward pressure, we just want to rub in a circular motion the top of the uterus here while the patient's exhaling. This is an uncomfortable procedure for many people, especially if they had an unmedicated delivery, but occasionally even if they did have an epidural or spinal anesthesia after a C-section, it can be fairly unpleasant. So while we're palpating the top of the fundus here, we want to be looking at the pad underneath them, and looking at their perineum to assess the amount of bleeding that's coming through. We want it to be scant to light, maybe just a little trickle. If it's pooling underneath the patient, if it's pouring out of their vagina, if you're expressing clots with your fundal assessments, then you want to notify your provider right away. If your fundus is not firm, then you would also want to apply more massage until it does firm up under your hands, and you would want to notify your provider because your patient's at risk for postpartum hemorrhage at that point. The reason that we do this is when the placenta is delivered, there is a wound that's left on the inside of the uterus. When the placenta is delivered, the uterus should contract down nicely and firm up so that it stems the flow of blood to those vessels and controls the bleeding. Unfortunately, for a number of reasons, sometimes your uterus does not contract down nicely. That could be due to just a lack of uterine tone, kind of exhaustion after delivery. It could be because there are products left in the uterus after delivery. Maybe a chunk of placenta came off and remains inside the uterus. Perhaps some membranes are left inside that can prevent uterine contraction as well. There could be some clots sitting in the lower uterine segment that prevent the uterus from contracting. And we see this fairly often, it's a full bladder. The bladder shares some space with the uterus, and if the bladder is full, it prevents the uterus from contracting down as nicely, and you can have more bleeding. Your fundus might be actually rising with your fundal checks if your bladder is filling up, or we will see some deviation of the fundus. So instead of being firm and midline, you would get it maybe to the right or to the left of the patient. So you would want to consider if they can void for you, or even straight cathing them if they're not able to do that, so that you can get control of the bleeding. Pitocin is often administered prophylactically after deliveries so that it can help with uterine contractions and keep that fundus nice and firm for you and the bleeding under control. Occasionally, patients would need extra medication. Usually, Cytotec is given. It's a pill that is either given PO or rectally. Sometimes Methergin or Hemabate are given. Those are IM injections that control bleeding, and TXA or transischemic acid is occasionally used. That's an IV medication for postpartum hemorrhage. Early breastfeeding is very important if your patient is choosing to breastfeed, because that stimulates the natural production of oxytocin, which can stimulate uterine contractions and control your bleeding and keep your fundus nice and firm. Other assessments that are wise to do with this, vital signs, of course. An increase in heart rate or a decrease in blood pressure could show that your patient might be at risk for or experiencing a hemorrhage. So after a vaginal delivery, after the placenta is out, you want to get right on that fundus and make sure that it's nice and firm, that your bleeding is under control. The frequency with which you do this would vary based on your hospital's policy, your provider's preference, or certainly your nursing judgment if your bleeding is heavier than you would like, or your fundus is not firm. I hope you've enjoyed this presentation here, and that it helps you in your practice. Thank you.